so we have a quorum, and let's get started in discussing a very top of mind topic, healthcare and politics, and truly how that influences our policies. And it is a burning topic because we are in the midst of a pandemic and it is impacting each one of our lives and livelihood. And quickly, before we start introducing our panelists, I want to welcome Bambi Francisco, who is my co-host, partner in crime for the Invent Health platform, and Mark Goldstein, who is joining from the UCSF Hub, who's also our partner in crime in a way. So with that, I would like to quickly set the stage up for a very robust conversation. Of course, we will share more about our partners and sponsors as we go forward. And I wanted to quickly share a very busy slide that shows how this is not our first pandemic or first virus that we have encountered in our lifetime or beyond. As you could see, we have had quite a bit of challenge in our in humanity with smallpox and polios and measles, and with huge, very negative R-naughts of the numbers that we talk about. COVID-19 is a new one, and we have dealt with all of these deadly viruses before, and we can deal with them with very significant public policies and public health interventions that we could do. As you could see, as COVID-19 hit us, how the world responded. And you see the world response and how it impacted our peak and curve. And different countries responded with different methods of putting hold on, shutting down, putting testing in place and things. And since we are in the US and talking about US, you could see that our responses have been spaced out and have been, not as impactful as we would like them to be. So the policy does become important in impacting how many lives are hurt by it and how much livelihood is hurt by it. And as we go forward, the impact of healthcare policies impacts different people differently. And as you could see, how our African-American population is much more differentially impacted by this pandemic compared to a regular population. And I included all of the different ethnicities and races, how they are impacted by resources and our policies differentially. And we see that this is not a one-way street. When the COVID-19 hit us, we needed impact of all of the policies in the healthcare side, in our policymaking, in our schooling, in our inventions, and our financial side. So, and it is bidirectional. So if the policy is made correctly, it impacts our coronavirus or COVID responses positively. If it's not, it impacts it negatively. One of the examples that I wanted to give is how science impacts healthcare policies. We had this science from 2007 that we know that when people wear masks, they are protected by outside world. When they wear masks, if they were sick, they protect the outside world. And how, even in COVID-19, we saw physical distancing, face mask, and eye protection has been quite effective. In the states where we did, these policies were followed. So you could see the states that did not wear masks, how just from the data today, they are in the peak mode. And so the policies do matter, and they directly impact their lives and livelihood. And back to you, Bambi. Since you are a financial guru here, you could share some of this data. You're on mute, Bambi.
Sorry about that. I'm on mute because I have my 8-year-old son running around here and I'm asking him to leave. But this is 2020 and this is how we do events these days. We have to be open to family getting to cameo appearances. So back to the slide. So this is really where public policies have impacted our livelihood as well as our lives. So just want to talk about the public health and what we did from the public health standpoint. So in January 31st, HHS did declare COVID a public health emergency. The FDA also loosened rules, this was about a month later, to expedite the development of diagnostic tests. So there was quick action. We also had a ban on China, and eventually in March, we extended some bans to UK and Canada as far as a travel ban. But in March, that was where we really saw a number of government fiscal policies come into play. Backing track, but let's say there was also, from the public health standpoint, we did see some announcements regarding social distancing guidelines and restriction of gatherings to 10 people. That's where we also saw a number of the states start to shut down the businesses there and move into sort of a shelter in place order. And that's where you can see where the economy clearly took a significant dip. But then in March and April, that's where we started establishing fiscal policies. And the government passed 3 main relief packages plus a supplemental one, all totaling around $2.8 trillion, the largest that everyone's familiar with, the $2.2 trillion CARES Act, which is the Coronavirus Aid, Relief, and Economic Security Act. There was also the Payment Protection Program that helped businesses that had 500 and under employees, so that helped businesses retain their employees. And then from the monetary policy side, the Fed cut its benchmark Fed funds rate first by 0.5% and then by 1%. So the government really, from the public health, fiscal, monetary policy, were really working to not only save lives, but to also cushion and provide a safety net for livelihood for people. So as you can see, when the businesses started opening up, and this was based on the jurisdictions, the local city and state jurisdictions, you could see by May, June, they started opening up, and you could see that the economy did start recovering, but you also could see from the public health policy, you could also see that we were doing a good job with the virus, and we still see a number of cases, but the caseloads have dropped. So this is how public policy impacted the economy, but this event isn't just about public policy. This is really about a public-private partnerships. Our event health is largely around the private sector and how technology innovators can impact a number of areas across digital health, like virtual care, mental and behavioral health, digital therapeutics, some of the other areas that we like, wellness, lifestyle as a medicine. Those are the areas that Invent Health has focused on. So this particular event isn't just talking about public policies, but how innovators can help public policy makers, because even though we're 9 months in, we're 9 months or 10 months in, and you can see that the economy is coming back up, we still have a lot of unanswered questions. Schools are still closed for in-person sessions. We still have conflicting data on the risk of the disease, as well as how we approach the disease. But I do want to say, from a public and private partnership, I think that that partnership worked really well around telehealth. We saw when the government deregulated telehealth in early spring, we saw virtual care advances take shape in months, in some cases weeks. And without the deregulation and the shutdown, some of these advances probably wouldn't have taken shape for years. So, but where we could probably do a little bit better would be under predictive analytics and precision medicine. And there's been so much talk about moving away from one-size-fits-all technologies into more personalized care, personalized diagnostics and treatments, and yet we're still not able to identify the people who are spreading this virus. So we'll talk about data.
The super spreaders, so to say, yes.
We'll talk about, yes, the super spreaders and some people think that some studies show that it really is sort of the 20% of those who actually get the virus are the ones who are responsible for the majority of the cases that are transmitted. So we'll talk about data, we'll talk about conflicting data, conflicting science, and how we can move forward. And I do want to bring on Mark Goldstein as well to say a few words, because Mark is at UCSF Health Hub, and along with HP and Vator, my company, we've been hosting these events typically in person for about 2.5 years now. I've lost count. So Mark, why don't you say a few words?
Hi, I'll keep it really brief. First of all, this is absolutely a great topic, and I'm excited to be a part of it. For those of you who don't know, UCSF Health Hub is UCSF's innovation center focused on digital health. This year, it's been a lot about remote diagnostics and telehealth and AI, and really we're in the business of helping small companies scale and grow. And it's either earlier stage, it might be finding advisors or investors, clinicians, people, folks that basically companies typically can't afford to hire. So they'll bring them on as advisors or consultants. Later on, we help companies get validated. We recently put on the UCSF Digital Health Award Show. And we're able to honor over 750 companies that are really making amazing changes in digital health. We work with all the other accelerators around the country and all the innovators at UCSF, and our relationship with Bambi and Archana goes way back. And for those of you who this is your first one of their sessions, I can promise you it won't be your last. And if you're not a member of UCSF Health Hub, please join. We have events all the time when we can physically. Right now we do a whole slew of webinars, some of which are ones like these, and with our partner Vator. So welcome.
Thanks, Mark. And thank you, Mark. And I forgot to mention, besides UCSF Health Hub and HP, of course, HP being our big partner, appreciate HP support. We do also have some other sponsors like StratPoint, which is a provider of engineering services, and Scrub, which is a provider of accounting services, and Advisor, a provider of advisory, typically M&A services. And we also have Alchemist Accelerator we partnered with recently to help us find startups, as well as Health Wildcatters. So with that, I do want to get this going. We are on time at 12:15, and I would like to introduce Bera, Representative Bera from California's 7th Congressional District. Congressman Bera is also a physician, and he's going to share a little bit about how Silicon Valley innovators can work with policymakers, a little bit on how the government's response to the pandemic, but not just from the federal level, from the city and state level, and also largely how city and states are actually working together to share data and to be able to make decisions. So with that, I want to pass this over to Congressman Bera.
Yeah, thanks for that introduction, Bambi. I'm going to break this up into maybe 3 sections and quickly initially just start on one of the early slides showed the different responses to COVID-19 in various countries around the world. And I do a lot of international speaking now virtually, but one of the questions I'm always asked is the shock that the United States has had one of the worst responses, given the resources we have, given the healthcare infrastructure that we have and the technology. And we can't avoid it. When we do the backward look, it wasn't because we didn't know this was a deadly virus. Early on in January, those of us that pay attention to this were aware that this was a fairly easily transmitted virus. Wasn't because we didn't dedicate the resources to this or have the healthcare infrastructure. That clearly was there as well. There were some debacles on the front end with regards to the initial tests that the CDC came out with, but at the end of the day, this was a political failure. And since that's the main topic, and the biggest piece of the political failure, and again, staying nonpartisan, was the decision not to take a centralized federal approach to this, and then work with the states and the local communities to both procure the PPE, the testing materials, coordinate and send resources where they were needed. Instead, the administration really chose to say, governors, do what you want to do with this. So you had a really uncoordinated response, 50 states doing 50 different things and competing against one another. And I really do think when we look back, that will be the real thing that we would have changed. We didn't have a coordinated response. So we find ourselves where we are. And I think as we assess where we are today, but then look forward, we should be very careful. The things that we could have done in March, April, May, in terms of flattening the curve, getting contact tracing in place, quickly identifying clusters, shutting those things down to keep our case rates from going up, would be very difficult in today's environment, given the real prevalence and spread of the virus, and the fact that at 40 or 50,000 new cases a day, it's very difficult to contact trace. So Bambi, I think you touched on it, where we have to think about this now is those super spreading events. Those individuals, the vast majority of folks who get infected don't transmit this virus to anyone else, or in a very limited capacity. But there is now plenty of evidence that suggests events like the Supreme Court nomination announcement are super spreading events. And how do we identify those events fairly quickly, concentrate resources, do some backward contact tracing as well as forward contact tracing to identify super spreaders, and try to shut those events down as quickly as possible, and create containment around these large spreading events and clusters. We are where we are with regards to politics, with regards to COVID-19 relief. I'm happy to get into some of that and what I think may come about. But let's talk about how the Valley can help us as we move forward to both contain this virus, but then also, as we think about the next virus, as we think about biosecurity and other things. And I think the Valley and technology in general can play a very pivotal role in where we are today in helping us, contain and get ahead of this virus. And, simple examples like, and we've had conversations with Valley companies like Kinza. If you want to do community surveillance, looking for warning signs, clusters of increased temperature, we've certainly talked to the search engines of the world and the Googles of the world. Are there particular searches that, people are, all of a sudden you see a spike in people searching for flu-like symptoms? Does that tip you off and say, let's direct resources or contact local public health agencies to send public health workers into a particular community? One of the areas that you touched on is, how do you take local data, county level data, state level data, aggregate that and work with the tech sector? Part of the challenge is the data collection systems, as we've seen in many local communities, many public health departments, are sorely outdated. And this is partly because of the neglect of local public health, certainly going back a few decades, but accelerating in the recession. So I would advocate that we don't just go back and try to use the data systems that are not doing an adequate job right now, but how do we actually build the systems that will serve us in the pandemic, but then also will serve us going forward? Because we, again, one of the prior slides showed the frequency of pandemics, and we know they're actually increasing. If you go back to SARS and MERS, and while Ebola is slightly different, but Zika and now COVID-19, we are seeing an increasing frequency of these pandemics, which should actually be expected because of the interconnected nature of the world and how quickly these pandemics can spread. So, at some point we will be passing another COVID-19 relief package, which will be in the $2 to $3 trillion range. I would hope it happens prior to the election. I don't know what happens post November 3rd, but again, it is clearly obvious to most of us that we will be throwing billions of dollars at both controlling the virus, getting past it, and then the economic help that families need. If I were sitting at a Silicon Valley technology company thinking about that, I'd be thinking about, what data systems, how can you use today's technology to collect that data on the front end, aggregate that data? How can you, help local governments that, again, probably don't do this very well, and federal government for that matter, probably have outdated systems, to aggregate that data and then get that back to the frontline healthcare providers to, again, direct resources where they need to go. And, again, we can get into some thoughts in the Q&A portion of that, but I wouldn't do it just for this pandemic, because I also think if we think about healthcare delivery in general, the commercial health insurance sector has just gotten blown up with this pandemic. The number of people that have lost private health insurance through their employer or employer-based health insurance is huge at this juncture. I don't know if that's going to come back or if it will come back fairly quickly. The number of uninsured folks or Medicaid eligible folks that are out there, and those are issues that are going to have to be dealt with, as the federal government becomes, a much bigger payer of healthcare, already the largest payer, but there's no other way to care for these individuals. And how do we build a 21st century healthcare delivery system? And I'll stop with this. And you have some really smart people on this call, like David Blumenthal and others who we've worked closely with. I think in healthcare, it always makes sense to follow the money and how things are paid for. And in the current system of a fee-for-service market, the emphasis is on quantity, not always quality. And I think you're going to see a movement, and it may be a fairly quick movement, to more value-based pricing, more capitated type of healthcare, where the incentives change a bit. And again, I think that's where the Valley can be very helpful, helping manage data, both in the private sector, but also in the public sector. And the public sector and the federal government clearly needs that data management. So I'm happy to stop there, and I'm happy to take about 10 minutes of questions.
That was a lot, Representative.
Yeah, we could spend a couple hours on any one of those topics.
Yeah, that's data. I do want to start, and I think if you're around for the next hour, we'll do you can also just mingle in with the panel, which is going to start in the next 5 to 10 minutes. But I wanted to touch on something you said from the very beginning, and we don't have to spend that much time on it because it's more looking back. And I'm not talking about backward tracing, but I'm talking about just looking back at the policies. But so, from the Constitution standpoint, the government, federal government gives public health and safety obligations to local jurisdictions. So from the federal side, this is a novel virus, as they say, but it was already issued on January 31st. It was already declared a public health emergency. There was already a ban or a limitation, at least in travel from China. There's already announcements to social distance and restrict gatherings. So from a national perspective, because I hear that all the time, there should have been a national policy. There's clearly a number of initiatives underway, including one of the largest fiscal packages, safety packages, that was passed. So from a national perspective, beyond those, what should have been done?
And I'd say those were inadequate. So you didn't put in, as soon as we knew this was a respiratorily transmitted virus, and we saw early data coming out of Wuhan, even if we couldn't get our folks in there, you saw this large city shut down essentially. The travel ban was fine. I mean, that may have slowed things down, but again, I had the first hearing on coronavirus, the novel coronavirus, before it was called COVID-19, and we pointed out that that would buy us time. What didn't happen was we didn't build up our testing capacities. We didn't do a quick assessment of our public health infrastructure to identify where those gaps were and quickly get resources there. We didn't institute a national mask-wearing proclamation that said, look, here's things that we actually can do to reduce the spread. And we still haven't done that at the federal level. We've left it up to 50 governors to make 50 different decisions about when they open. And I'm fine that, you know, some local control is necessary, but I think you have to provide that guidance to say, here's what the science suggests. And lastly, I would have left it to the doctors and the scientists at the federal level working in conjunction, because the truth is the resources are going to have to come from the federal level. The CDC's, you know, while its reputation has been smeared, if you actually let the doctors and scientists at the CDC provide the best recommendations, we would have actually done better on this. But rather, you know, these agencies have all been politicized right now. You're seeing it around vaccine development, which is going to be pretty dangerous.
And I also want to second that thought, you know, how centralizing the response was absolutely needed, especially a virus that is not held by borders. So people were still traveling across states. And we notice in larger corporations, the private response, the private employer's response to the virus was much more centralized, and hence the impact of the virus on the population of these larger employers was positively impacted, and people actually had lesser numbers because they filled in the gap where the public health didn't. The other thing that also the positive that, you know, Congressman talks about the data part, we did see, you know, partnerships and data gathering has been one of the important awareness tool. John Hopkins site that was gathering up all of the data around, you know, recovery rate and incidence rate was really helpful for people to see hotspots where they can avoid going and maybe assess their risks a little bit better. So data does become really, really important in people to make decisions and education around that.
So Archana, you mentioned that the private sector did a great job, I guess, from the corporate standpoint. They decided, many corporations said, stay home. I think that's what you're referring to. But remember, from the testing standpoint, so the CDC had problems with their testing capabilities, and I mentioned the FDA loosened rules on February 29th. February 29th, they loosened rules to expedite development of diagnostic tests. And we're 6 months later, and some of those tests are still inaccurate. So we couldn't even get the private sector to get their house in order. I mean, actually, if you look at it, and this was going to be a question for the first panel, you know, 6 months actually for a novel coronavirus, maybe that is pretty good. But to say that we should have had testing from a federal level done in January is to in order a national mask mandate, when I think if we had a different government, I'm not quite sure who would actually have a national mandate, because I don't know any of the two candidates, our president and the vice president, President Biden. I think he is even backpedaling from ordering a national mandate. So I think it's easy to say, well, let's have a national mandate. I think it's a lot harder to pass something like that.
So you can't pass a piece of legislation, but you can make that recommendation based on the science, based on what we know, based on the slide that you put up. We understand that it reduces transmission. We are getting better therapeutics. You know, we are getting better diagnostic capabilities, but honestly, going back to January, if you look at the Asian countries, Taiwan, South Korea, et cetera, they were taking the test that was developed in Germany and using that test. I didn't, you know, when the CDC announced that they were coming out with a better test, we all took it at a grain of salt. This is the CDC. It'll be a better test. That was a self-inflicted wound that the CDC test had some flaws in it. So yes, that was a mistake, and that was a self-inflicted wound. But there's no reason we couldn't have actually ramped up testing capabilities, used the Defense Production Act to say we need this if we want to get a handle on this and get ready for when we do the reopening. Let's put together a national testing strategy. Let's start hiring all those Peace Corps volunteers, all those AmeriCorps volunteers, and training them to do contact tracing and deploy them where they need to go. Let's also not have 50 states competing for ventilators. Instead, let's actually, at the federal level, procure the ventilators that we need and send them to the hotspots. Let's send them to New York in April and May. Let's send them to Florida in July and August. And we just don't have that coordinated response that's moving things up. So yeah, I beg to disagree that it is embarrassing that we are still talking about testing 6 to 9 months later. There's no reason that would have been the easiest thing to solve.
So, and it is not about mandate, like it is about providing resources. So at a centralized level. So even though Constitution kind of guards against mandate, but it is providing the ventilators, providing guidance and recommendations is never off the chart, off the table. And so those are things absolutely we could have borrowed technology from Germany for testing, for goodness sake. Like there's so many things. Yes.
Yeah, the majority of the world used the German test, which has proven to be fairly reliable. And Bambi, I agree with you that early on when the FDA loosened the rules, a flood of tests came on the market that had questionable sensitivity and specificity and some a pretty high false negative rate on some of this. Testing's gotten better, but we're still not anywhere near where we need to be right now.
Sure. It's 12:35, and I see most of the panelists here.
Yes.
Some are pinging me, like Esther, she pinged everyone. Yes, Esther, you're right. It's not just about rules, it's about culture. We do live in a free society, and people should be able to make the right decisions with some guidance. So I agree with you there. But I think, Archana, what we should do is we should bring in the other panelists so they can get involved in the discussion, because they look like they're chomping at the bit here, wanting to say a few words.
Yes, absolutely. So we can begin with like introductions, quick introductions, and then we can jump into a very robust conversation. And since we are on the Zoom session, I will keep, calling out names that are along on my screen. So then I begin with David. David, can you come on off mute and then share and introduce yourself and share how you're involved with COVID-19?
Great to be here. Thanks for having me. My name is David Blumenthal. I am president of the Commonwealth Fund, which is a organization that does research and policy development to improve the healthcare system. We are involved in all things healthcare and have been active in thinking about COVID-related policies. I've written a fair amount about it personally, and we are also now looking very carefully at one of the topics that you mentioned, which is the intersection between COVID and disparities in racism. So we see that as a pressing opportunity right now on our agenda.
Excellent. Thank you, David. Thank you for joining in. I have Sally, who is the next tile on my Zoom screen. Sally, you're on mute.
You're on mute, Sally.
Yes.
But phew, modern technology is just a step above me. Anyway, but I'm Sally Pipes, President, CEO, and Thomas W. Smith Fellow in Healthcare Policy at the Pacific Research Institute. I've been involved in the healthcare policy debate since my days in Canada at the Fraser Institute. And I write regular columns for Fox, Forbes, Washington Examiner. And my latest book is False Premise, False Promise, The Disastrous Reality of Medicare for All. And I'm very interested in the intersection of the idea that if we had Medicare for all, a complete government takeover of our healthcare system, that the COVID would be a lot less. So anyway, so I'm very involved in the policy debate on healthcare reform.
Thank you, Sally, for joining us. I got Esther on my next screen. Esther, can you please introduce and share what your COVID interactions? Yes.
So I'm the executive founder of Wellville, which is a 10-year nonprofit project to work in 5 small communities and address health and disparities, not health care as much as health. And we're focused on long-term thinking, on investment in health, rather than coming in when COVID strikes and trying to fix people with remedial care. And just as these disparities create huge disparities in who dies from COVID, they also create huge disparities in who is well enough to work and get a job, who doesn't get addicted, people with these chronic conditions that are due to lack of health and resilience, they die early too. They die with cancer early. They die with chronic, pulmonary disease early. It's, in a sense, death is not the worst part of it. It's living with these chronic diseases that take away years and years of quality of, just happiness and ability to live versus sitting around suffering and, whatever. So I encourage us to use COVID as a way of looking at these long-term problems and solving them. Even if we never have another pandemic, half this country is in poor health and doesn't need to be.
Thank you. Powerful thought here. Donald, you're next to me, next panel. Thank you for joining us. Please introduce yourself and off mute first, and then share how you are helping with policies, and especially in COVID times.
Thank you. Were you, you're throwing it to me, right?
Yes, I am.
Okay. Well,
Mhm.
my contribution to helping with policies is to try to show you some evidence that the policies that we and everyone else in the world have tried so far have been an utter failure. And we had, I'm sure, the best of intentions going in, but you know what they say about the path to hell. May I have your permission to share my screen and spend 5 minutes showing you some slides? I can just talk to it, but pictures are always better.
Yes.
All right. I'm going to show you, oh, I tried to share my screen, but the host has disabled participant screen sharing. So I guess we're just going to have to talk about this.
I can let you, well, I guess I can make you a...
Make me a co-host.
Go ahead.
Yes, you should be able
I won't
to do
abuse
that.
my power.
I've heard that before.
Yeah, right.
You should be able to share now.
All right, I think I can. All right, here we go. All right, so what we're looking at some empirical research that begins with the University of Maryland's Social Distancing Index. The University of Maryland's Transportation Institute takes the Google cell phone tracing mobility numbers and puts them into an overall social distancing index that gives us not simply a look at what presidents and governors and county supervisors tell people they ought to do, but what they really do to be locked down or not, to comply or not. And we detect that by the mobility or lack thereof of their cell phones. We can look at this on a very granular basis. The display you happen to be looking at right now is the United States overall this year to date. Now, I'm going to show you what happens if we compare the results state by state at controlling fatalities from COVID-19 indexed against the degree to which, state by state, people socially distance themselves. And the way I'm going to do that is for each state, I'm going to take the daily social distancing index value, where a small number means you didn't get very distant and a big number meant you got very distant. And I'm going to add them up over the 3.5 months from January 1st to the peak of social distancing, which was April 10th. And I'm going to assign each state a lockdown score, and I'm going to rank them from least lockdown to most. Here's the score. Idaho was the least lockdown. District of Columbia was the most lockdown. Here's all 50 states plus DC in order. Now, what you would expect if you laid those out on a scatter plot with that cumulative social distancing index on the horizontal, least distance on the left to most distance on the right, and you laid that out against fatalities as a share of population on the vertical, you would expect to see the least lockdown state, Idaho, having the most deaths. You'd expect the District of Columbia to have the least deaths. You'd expect this to be a highly correlated series with a huge R squared. Unfortunately, you see this. It looks nothing like you would expect. The regression line actually goes the wrong direction. Now, I know this is going to be very, very hard for you to believe, because from first principles, if you have an infectious disease, I admit it makes all the sense in the world to try to isolate people from each other in order to prevent them from spreading it. But it turns out to not be that way. And by the way, we all have a big investment in having done this, and it would be very embarrassing if we caused a depression for nothing. But that is what the backward-looking empirical evidence tells you. It's telling you with an R squared of 0.4086 that it hurt to lock down, not helped in terms of controlling fatalities. DC was the most locked down, as I said before, well above median result in fatalities. That's not the direction you want. Idaho, which is the least, did better. We can look at the 15 least locked down states. All but 3 did better than median in terms of controlling fatalities. The 15 most locked down, all but 3 were worse than median. Now we could run this experiment a second time. We ran it during the lockdown period. Now we'll run it again during the open up period. About the same number of days from about April 10th through early August. You get exactly the same result. Different states in different positions, but you get the same result. With almost as good coefficient of determination, you get this very unpleasant report card that it costs lives to lock down. There's the median, there's DC, the most lockdown, well above median, just almost as bad as it gets. Wyoming has been the most opened up state during the era of opening up, had a fantastic result. Now, I've talked to many people about this. We originally did this research in April. This style of research has been reproduced in a publication of The Lancet using not American states, but different countries, using these very same metrics, and they came up with the exact same result. So it's not just me. It's not just me, a crackpot economist talking to you from Dallas. The most prestigious medical journal in the world has come up with this exact same result. Now, I know what you're thinking. You're thinking, well, it just must be something else. It must be that there are very different population densities between these places. So, I mean, Wyoming certainly can't be compared to the District of Columbia. Well, we've looked at this at the county level, the city level, the zip code level, the congressional district level. You get the same result. It doesn't matter the average age of the population. It doesn't matter the racial composition. It doesn't matter the weather. It doesn't matter the number of people as a share of population in nursing homes. The only thing that has any explanatory value at all that we've found is the intensity from state to state of rapid transit utilization, which I guess goes some way in explaining the terrible experience that New Jersey, New York, and Connecticut has. So I hate to be a nihilist, but I'm here to tell you that what we thought would work didn't work. We caused a depression for nothing. We probably made it worse. So I'm ready to take all of your angry questions.
No, it's and I think what you just mentioned is that the rapid transit transportation and also international flights and how the populations, especially knowing what kind of economies that they hold, is a lot of transportation or people movement in these areas where we see increased amount of incidents, and also dwelling too. If you look at New York, there is a lot of apartments and common spaces that people are encountering. And we, some of the data that Lancet itself has looked at also talks about how people dwell and how people transport themselves matters, and on the top of these.
I would just like to add that there are other places in the world than New York that have heavy reliance on mass transit in the form of underground subways. Mm-hmm. Japan comes to mind, Hong Kong comes to mind. And for those of you who've had the experience of testing all 3 of those systems, you know how different they are. You know that the systems in Tokyo and in Hong Kong are sparkling clean. People wear masks if they even have a sniffle. And it could not be more different than those petri dishes on wheels called the New York City subway system.
Yes.
So unfortunately, we didn't lock down the New York City subway system. Oh, we locked down the schools and the parks, but it wasn't until the worst of the lockdowns were over that they even shut down the New York City subways at night to clean the damn things. Well, at least after all these years, they finally cleaned them. Too late, too many people died.
Yeah. Yeah, and to Esther's point, yes, the mask data, there's plenty mask data out there. Like there is no debate at this point that the masks help, whether you change nothing else and you just wear masks, that changes a lot. Joel, thank you, Don, for sharing of a data that we will, probably fight a lot about, hopefully in this conversation. You're firing up the conversation. Joel, you're next, and please introduce yourself and then share how you interact with COVID.
Sure. So primary interaction was my son was infected, but that's a different story. Joel White, I'm the president of Horizon Government Affairs. Worked on Capitol Hill for a dozen years, writing a lot of the laws that we now live under, including health savings accounts, Medicare Part D and Part B, drug reimbursement, et cetera. But at Horizon Government Affairs, we represent a couple dozen clients who are all working in marketplace to address COVID, either through vaccines or treatments or in providing insurance or new products like telehealth and digital solutions. But we also run two coalitions of about 200 different organizations, each with an interest in reforming healthcare to make it work better. And one is really focused on the affordability issues and coming up with market-based solutions to create competition and better pricing to lower costs. And in that sense, we've been looking at what are some of the fissures that COVID has exposed that really point to some gaps in our current system. And in particular, we're looking at really Medicaid and COBRA from a coverage standpoint, but then also hospitals and how care is delivered and how we could do it better. And then the second coalition that we work with is called the Health Innovation Alliance. We just produced a report through the Heritage Foundation on just what Don was talking about, the absolute dismal failure of our ability to just assess and understand what's happening on the ground from a data standpoint. And, for anyone who's gone to the Johns Hopkins University website or to the Atlantic Monthly's a daily COVID tracker website, there's a reason you're not going to the CDC website, right? Like there's a lack of timeliness, accuracy, and precision in the data that is really just causing us to fly blind in a lot of states and nationwide, and Congressman Bera pointed to this. So in the report, we basically argue that we need a new system that would facilitate the collection, use, analysis, and sharing back to clinician to be able to make good decisions on clinical care, public health, and public policy. And that would lead to standardized data using the same systems that we use to practice medicine to report the data, and then creating a data hub that would create a two-way street for our public health data system that's interoperable, privacy protected, secured from CyberSense, and really a modernized public health data system that informs a clinical and a public health system. So both those coalitions have been doing a lot with Congress and the administration. Our hope is that we will have a new modern public health data infrastructure here within the next 2 years, and that we would have some real care delivery and payment delivery changes on the ground through Congress and the administration over the next 2 years as well.
Great. Thank you. Thank you, Joel, for joining. Amber, you are next on our panelist. Thank you for joining.
Thank you. Good afternoon, everyone, and thanks for having me. My name is Amber Hewitt. I'm the Director of Health Equity at Families USA. We're a national nonpartisan health consumer advocacy organization. We've been around for over 35 years. We are dedicated to achieving high quality and affordable health and healthcare for all. We have 4 focus areas: health coverage, health equity, healthcare value, as well as elevating the consumer experience. I'm also a recovering academic and researcher. I started my career as a tenure track assistant professor. I have lots of questions for Donald, but I don't think we have the time to go into those in this setting. In May in Families USA, I co-authored a report called The Fierce Urgency of Now. And it identified short-term and long-term federal and state policy recommendations. And part of that analysis, we did a multi-county analysis of 11 counties across the country. And we found that counties that had the highest rates of racial and ethnic disparities in COVID-19 outcomes were also the same counties that had the highest levels of community disinvestment, as well as they were poorly ranked amongst other counties in their states for things such as access to high quality education, transportation, nutrition, et cetera. So when it comes to our health equity policy lens, we take a close look at the social determinants of health and the social and economic drivers of health outcomes. Because as we know, it's not just about the care that is delivered in the healthcare setting, and how all of those things are also in the context of other sort of macro and contextual factors such as structural racism. So our involvement in COVID-19 has been around our legislative and our regulatory advocacy. We've engaged with many Hill offices, and we also deploy our deep partner relationships with state and national health organizations.
Excellent, thank you, welcome. With that, back to you, Bambi.
Yeah, so we have a lot of people here. We've also talked a lot about policy, and I really wanted to talk more about policy with regards to COVID, but I also wanted to spend a lot of time talking about the underserved communities here and addressing underserved communities, because obviously that when 2021 and beyond, we're still going to need to address how we give access to those lower income communities. So I want to start with Sally, but also mention that we do have a couple of questions here. They are actually targeted to Don. So, beware when you start putting out slides, Don, controversial slides like that, you are going to get people who want to ask you questions. So we will do that. And I definitely want to get Joel in there to talk more about data as well. But Sally, so you had a number of people you're talking about. We really need to do something to address underserved communities. COVID clearly exposed the vulnerabilities that we have in the healthcare system with regards to taking care of those communities. We do have a number of policies in place. We have a number of initiatives in place, whether it's the, this is COVID related, $15 billion in COVID relief payments for Medicaid and children's healthcare insurance. We have almost $50 billion allocated as part of opportunity zones for affordable housing and zone community projects. So how do our innovators and our community advocates, are they able to get access to these funds to be able to develop a better system, healthcare system for underserved communities? Hold on. Hold on.
Sally, you're on mute.
Unmute. Okay, am I unmuted now?
And I
Sorry, it
volunteer
didn't
after
show
her.
up.
And then Esther is going to go next. Yes.
Right. Okay. Well, and thank you again for having me. I'm delighted to be part of this discussion, and I really enjoyed Don Luskin's always efficient economic information that he puts out that I really enjoy. I think it's far from clear that diverting yet more taxpayer money into a program like Medicaid is really going to do anything to improve the health of the poorest Americans. The best available data on this question comes from a landmark study of an expansion of Medicaid in the state of Oregon pre-Obamacare, and it found that Medicaid patients post health outcomes that are no better than those who are uninsured. And a new report from the CBO, the Congressional Budget Office, shows that of the 30 million uninsured last year, 1 million were eligible for Medicaid and CHIP and didn't sign up. And I think part of that reason is that if you're on these programs, it's often harder to find a doctor because doctors are reimbursed about 38% below what they get for treating private patients. And so many many docs won't take people who are on Medicaid and kids who are on CHIP. But there's also compelling evidence that Obamacare's expansion of Medicaid has really helped fuel the opioid crisis in this country. The program Medicaid should really be a last resort for what I call the truly needy. Instead, it covers roughly 1 in 5 Americans. People, about 65 million Americans are now on Medicaid, and many of them are able-bodied people that could actually be at work. And so I think the only way to truly help the least well-off in the long term is through policies that spur growth, create opportunity, and encourage economic independence. A program that rewards healthy working-age Americans for earning less and remaining unemployed doesn't do it for me. And so I think, you know, these are things that we really, you know, have to look at. And so the underserved under Medicaid are not doing well. And as I say, part of it is because a lot of docs won't take them. And we've got, you know, as I say, 65 million people now because of the Obamacare and the expansion, adding 15 million to the program. So it's a lot of government money, which isn't going to solve the crisis. And I think, you know, we really need to have an education program and really get well-educated American kids so that they can get good jobs and not be dependent on government. But I think Medicaid and CHIP, as I say, 1 million people at least could sign up but haven't, and I think it's because they can't find a doctor. And emergency room use is up because a lot of these people can't get care through the Medicaid program.
And you know, the only clinician on the panel at this point, I could just totally confer to what Sally is saying, that the reimbursement from the programs like Medicaid or CHIP is much less for the providers. And so they'll end up getting poorer quality providers. And the opioid crisis is more not related to coverage, is more related to emergency room use. The amount of, you know, pain medication dispensed out from urgent cares and emergency rooms, and poor quality providers who are providing for the folks. So it's not direct relation, but indirect. So we are kind of distinguishing between correlation and causation. Here it's more a correlation because of indirect access to the opioids.
I think.
Okay, can I?
I can't believe we're debating the value of insurance.
I think she was. I think Sally was also just referring to incentives.
Yeah, I'd like to. If I can just weigh in here, I don't want to turn this into, you know, like a Sunday morning argument panel. I agree with Sally that these programs are poorly designed and they don't compensate the medical professionals effectively. What we really need to do is, and this is very simple but very hard, we need to think long term, and we need to start investing in people's health. I mean, there is this wonderful story of, you know, all these people kept driving off a cliff because the road was badly designed, and so they set up emergency care at the bottom of the cliff, and they brought in ambulances and they brought in care workers, and, you know, like, no, fix the road at the top so people don't fall down the cliff. And fundamentally, we need to price the externalities of things into, on the one hand, bad food, but more than that, we need to pay teachers and care workers and doctors better so that kids don't become damaged and unhealthy by the time they get to school. Then they proceed to not listen in school. They go to bad schools if they live in poor neighborhoods, and especially if they're Black. They, you know, all the things that come with not being a white rich person. And then they drop out of school, they can't get jobs, they commit crimes, they become addicted. The opposite of taking drugs is not taking drugs. The opposite of taking drugs is having a job, having a purpose in life, having kids. And this is not something you do by applying doctors and hospitals at the end. It's something you do with good schools and healthy communities at the beginning. We need, obviously, to care for the people who are in crisis right now, but what we really need to do is change our long-term policies. There's lots of scientific evidence I could fight back with around the impact of nurse-family partnership and childcare and basically all these early interventions that keep people from getting sick in the first place.
Bambi, I'd like to know how we can be most helpful to your audience, because debating the value of Medicaid, debating the value of investments in health versus healthcare, these are very, very old, tired debates. If you want to go through those again, we can take up time talking about Medicaid's effect on the health of populations, which there's plenty of data. We can talk about the value of insurance, which the National Academy of Medicine has looked at multiple times. We can look at the results of some of our work. I don't really want to go through that because that's not a very helpful discussion right now in the midst of a pandemic. You know, I think, and not only that, but the Congress has spoken multiple times on Medicaid. It's not going anywhere. It's not perfect, but it's not going anywhere. And it does a whole lot of good for millions and millions of people, especially children who otherwise would not get any access to healthcare.
Yeah, and I think just to balance this off, first of all, I think that we want to talk about the private sector, right? Not so much about Medicaid and what government's doing, and because government is providing on both sides, Democrat and Republicans, they both provide safety net and they're providing Medicaid. I'm a big believer in what Esther said, which is we need to think long term, even Invent Health. If you think about if you've gone to our website, mine and Archana's, we talk about lifestyle as medicine. So this is not about, we want to take people out of the sick care industry, the 3.7 trillion or whatever it is.
We're in the middle of a pandemic that's killed 210,000 people. Long-term investment in those people's health is not going to save their lives. We needed a healthcare system, acute care system that worked, one that was responsive to a pandemic. So I don't disagree with the need to take care of chronic illness and management, but we need an acute care system too. And that system failed utterly.
Well, let me ask you something then. Everybody else can chime in, because Archana and I were talking about this. There is money out there. There's money to be had, provided by the government, whatever your thoughts are about the opportunity zones, but apparently about $47 billion allocated for housing and zone community projects. There's also a $5 billion tax credit to expand school choice. I know this isn't COVID related, but 69% of Black Americans, if we want to talk about a racial discussion, they support school vouchers. There are policies in place and money in place to help the underserved communities. I'm not blaming anyone here. I'm asking, are we doing a good job funneling that money to innovators so we could take advantage of that? And if not, how can we? Because the government is doing its job by providing and allocating funds, but we don't seem to be getting that into the right hands.
As they say in Russia, the funds fall off the truck. You know, somebody nabs them before they actually hit the people that they're supposed to be serving. A lot of opportunity zone projects are actually gentrification with expensive apartments for rich people that basically displace the poor people who live in the opportunity zones. A lot of the money has gone to large companies and has gone into executive bonuses. It's, you know, and the problem is you can't solve the impact of these long-term problems short-term. We certainly could do a better job of just supplying our hospitals with PPE, with the contact tracing going backwards. And, you know, there are some things the private sector can solve, but some it can't. To be constructive, backward contact tracing and wearing masks are probably the two most important things we could be doing right now. And that unfortunately requires a culture change.
Yeah, and I think what we are clashing right now is two things. One is we have to think long-term, but we also need to think short-term too, because to David's point, we are in the midst of a fire and we cannot be building the foundation at this point. We need to also look at first contain the fire and then work on the foundation for the house. And so how do we create that public-private partnership that fuels innovation in the field of testing, which is what, Esther, you were talking about. Like, we need testing, we need masks, we need education of masses, and also resources to the area where it is impacting the most. And I just shared in the slide where people who are racially and ethnically, it is impacting populations differentially too. And it's not just genetics, it is resources and access to those. And as we are lighting off this fire, we need to also have a little bit different approach to different populations. And so, David, the question back to you is like, yes, we shouldn't think long-term at this time in the middle of fire. What can we do for a good, effective public-private partnership?
So I believe totally in the need for investment in the determinants of health, and we should be making those. But the most important investments that we need to make right now in the next 6 or 8 months or a year is in providing adequate care to the acute care facilities that care for our most vulnerable populations. The first funds of the CARES Act went to the richest institutions.
Yeah.
It was determined, it was allocated in proportion to their net patient revenues. The more commercially insured patients you had, the higher your net patient revenue and the more you got per patient. So the safety net institutions like those in New York and Houston and Los Angeles and Detroit, who were bearing the brunt of this epidemic, were getting the least per patient revenue. And right now, there's an additional $15 or $20 billion, Joel can probably correct me and give me the exact figure, that's waiting to be distributed, but we don't know what the criteria will be for that distribution. So I think the absolutely first thing we need to do is develop federal policies using the taxpayers' money that help the people most vulnerable in this pandemic. So that's point number one. Then we also need to develop effective ways of getting people to wear masks. And Mr. Luskin did not attack the mask idea, which is probably the most important social factor and needed to be controlled for in his analysis. So we need to find a way for leadership at the national level to overcome the resistance of local leadership doing what is in the best interest of their populations, and that is to encourage mask wearing, and incentivize it strongly for the best, not only for their benefit, the benefit of their own citizens, but the benefit of citizens in adjoining states. Because as long as there is active COVID in any state in this United States, every state is at risk.
So let's get Joel in there because he did, and we'll address the mask question to Don later. But Joel, why don't you pick it up?
And I'm flattered that Dr. Blumenthal can just assume that I can pick those billions out of my head. I used to be able to do that, but once the trillions started flying around, the billions became less relevant. This is why data is so critical, because we have a crisis in the hospital and the community level for a lot of reasons, but what we know about this disease is that it disproportionately, almost overwhelmingly affects older people and in a significant way, either through hospitalization or death. And a lot of what we need to invest in is nursing home care and geriatric care, quite frankly. And that is very much a short-term need. And so the funds that are coming out of the provider fund that Dr. Blumenthal referenced really need, I think, to be targeted in those areas. We shouldn't have given it based on a historical Medicare per capita, figure, because it did reward those rich institutions and didn't send the need to where it was greatest. So that's kind of this short-term thing. But the other thing that he alluded to was that we've got this very old model of care in the U.S. and hospital care, and it's kind of based on this high volume throughput, get the beds filled up and get reimbursed. And what we saw during the pandemic as the elective care got shut down, that model kind of fell apart, and we had hospitals kind of burn through their resources in a month and a couple of weeks, in 2-month period. And all of a sudden we needed, to send the taxpayers in to prop up that model. And so I think we need to be thinking a little bit more creatively about maybe we have there's an old TB hospital program, and we would separate these infectious cases out and allow folks with cancer and heart illnesses and other things to go to the other facility. We need to start thinking about models like that again. But one of those models we need to think about is community-based care. And so if you had a cancer patient or a diabetic or a heart disease patient who was waiting it out, they weren't going in to get the imaging or to get the treatment because they were concerned about being infected or because the elective procedure was actually shut down. They didn't just sit in place. Their disease didn't kind of automatically suspend. They got worse, right? And we're going to incur a lot more costs. So we need to start thinking about how do we create safe community care zones where we are testing rapidly to get people with compromised immune systems the care they need, versus telling them to sit at home and wait it out. That needs to have a high priority. And I think telehealth is a big part of how we treat those with current illnesses in safer places like the home setting. We waived almost every government rule for telehealth in order to get that care delivered at home. We should never go back to the old way of doing telehealth, where we're saying you got to go to the hospital or the doctor's office to get reimbursed and all that other nonsense. That needs to go the way of the dodo bird. And then finally, I would say, just from a longer term basis, because it was brought up, I think hospitals and healthcare workers are happy to pitch in when crises and pandemics happen. But if we kind of want them to be more involved in public health on a long-term and consistent basis, we've got two choices. We can force them to do it, or we can pay them to do it. And what we haven't been willing to do is pay them, willing to invest in those systems and pay them to do it. You get more of what you pay for, less of what you don't. We need to start making consistent long-term investment in having modern health systems to address crises as they emerge.
And may I jump in?
Yes. Yes, I was about to come to Amber. That was my question for Amber is, how do you respond to the response to COVID, and how does that influence this?
Yeah, so I've been taking notes because I feel like we've been talking about lots of different topics all related to our current crisis. So I first just want to build off of what David said. I completely agree related to the need to focus on acute care and that this is a crisis. As he mentioned, over 200,000 Americans have died. And I think we have to keep saying that because I think sometimes we get numb to that number and just used to that number. We're also several months after the House passed the HEROES Act. I know they recently updated that legislation, and the Senate has yet to act. So I think that cannot be overstated. And I also wanted to clarify my remarks on the social and economic drivers. I was trying to put our current pandemic into context. So I hope my remarks weren't taken as sort of pitting short-term versus long-term investments. I think when it comes to talking about the disproportionate rates on for example, Black, Latinx, Indigenous, and other people of color, we also have to understand sort of why the current pandemic has exacerbated those inequities. So that was my my reasoning for talking about those social and economic drivers. And when we talk about public and private partnership, again, my focus has been more on the public sector and public policy. And as the Congressman mentioned earlier, and as others have mentioned, we have, and I think Esther has put a couple times in the chat box, that we lack that coordinated, that national coordinated strategy, and sort of pit states against each other when it comes to resources. We have states setting different benchmarks for what's considered an outbreak, and all of that leads to sort of disparities in reporting and sort of clouds the picture. So I also wanted to comment on something that Sally mentioned earlier around, one of the reasons why folks may not want to sign up for Medicaid because it's difficult and hard. I'm not necessarily disagreeing that, signing up for health coverage is completely seamless. But one of the things that was in the House package, and one of the things that we talk about from the health coverage perspective, is making sure that there is funding for consumer assistance and navigators. And we also have to think about this crisis and how it has both a health and economic crisis, and folks are losing coverage, and we can't take that out of the equation. I think it really amplifies the need for comprehensive health coverage. And I know Bambi may be posing a question later when it comes to public option, but those are just some of my comments based on what's been said so far.
Well, I want to bring in Sally, because it does sound like a lot of people are saying that we need a coordinated, we needed some coordinated effort here, maybe a national effort here, and maybe it's around standardizing around data collection, because I think there's also what I'm hearing is the data that we're collecting is not standardized. So maybe you can talk about that from a policy standpoint. You know, what could the government do better right now to address some of these issues people are bringing up? And then particularly what Joel also mentioned was the community-based care. There's nursing home care and geriatric care also. Those are the two areas that sort of David mentioned too, like those areas that we need to focus on now. What can government from a federal level, a policy level, what should they be doing? Or what would you advise them to do?
Right. So I wanted to ask David, when we get back to the issue of the mask issue, do you support a national mandate for mask wearing? When we get back to that, if you could answer that question. I mean, Mr. Biden has been sort of back and forth on that. So I wondered what your thoughts were on the national mandate for wearing masks. Thanks, Bambi. The infrastructure at the CDC and the changes that we need. What can the private sector do? I mean, I think the CDC is really sort of it's so far behind in what has been happening in the private sector. It really needs to transform its data technology. It lacks uniform data collection standards. Some data are collected, manually by frontline people, handwritten forms, faxing. I mean, this is just, high boots and high button shoes sort of stuff. We really need effective surveillance of an outbreak when in real time data are reliable and consistent. And so given the state of information technology in this country and what the private sector has been able to do, it's unacceptable that the CDC has such an antiquated system and so many people rely on it. The FDA as well, they need to streamline their regulations, work with, the Microsofts of the world and the Googles. These people have, scientists who are so creative at developing, alternatives and great system. Why aren't they using, the private sector to advance? I mean, the whole issue, on testing, and the FDA is tightened up. I mean, we just heard the other day that Alex Azar said that now vaccines, they need much more control on approving vaccines. It's not going to happen until later because more and more government control. So I think we need to get the private sector more involved and not rely on the CDC and the FDA for their information, because they're backward and we're not getting the right information that we need in order to get the pandemic under control. We really need to be protecting the vulnerable. And we know that 80% of the people in the COVID deaths statistics, 80% of them are people 65 and older, most of them in nursing homes, and 32% are people over 80. We need to protect the vulnerable, but we don't need to shut down the economy and schools and things that, whereas in Vaughn's statistics, we need to open up and get the economy moving. So I think the CDC, unfortunately, is sort of caught in the past, and they really need to work with the private sector to develop modern assessment tools instead of the way it is right now, and the FDA as well.
Well, I want to bring in Joel to respond to that, but then get to David's mask question and respond in there as well. But Joel, you really want to look for some standardized in terms of standardized way is standardizing the data. Now, Sally says we should get that from the private sector versus, letting the top down the CDC or HHS determine what that is. Makes some sense. What are your thoughts in terms of who, where should we start getting standardized data gathering? And should it be from the private sector?
It should be from the private sector. The basic takeaway here is that, a lot of what we're talking about today has been what's been the government response to COVID. And across the board, we see failures, right? And really just a system that's lacking in seriousness and response. In the CDC, we did this paper, Doug Badger and I did this paper through the Heritage Foundation. We looked at the collection and use of public health data. In 2006, Congress saw the need for a nationwide, interoperable, near real-time data network to really track public health pandemics. And so they enacted a law. They told CDC to stand up that system, right? To stand up this nationwide data network. That was 14 years ago. And CDC failed to do it. And in 2013, Congress passed another law and said, we're really serious, do it. Here's some money and here are some benchmarks. And the CDC failed to do it. So Congress passed another law in 2019, and CDC still has not done it. So the simple truth is, I think they have the law, they've got the statutory mandate, they've got the funding, they just lack the leadership to kind of take this on. And that's been true over 3 different administrations. So you could hire 1,000 different companies out there, many of whom are in the Valley, to stand up a modern data management system that would do a better job than this. I always point to my friend Avi Schiffman, who did stand up a COVID tracking system. He's a 17-year-old senior at a high school in Seattle. And he stood up a system in January because he was so frustrated with the CDC approach. He's had 1.7 billion unique visitors to his website. So we can get this done. We can do it quickly. We don't need to invest a lot of money. It's just managing information. So what do we need? We need standard data elements. So that requires the standards development organizations to come together and define what it is we need. Fortunately, a lot of this data already exists in EHR systems. So 100% of our hospitals have an EHR. We can automate the reporting of that data out of the EHR systems and send it directly to the public health offices, who could then use it and analyze it and spin it back to the clinicians to make good decisions. But we need a data hub to do that. So that's the third element. So standardized data, automated reporting, and a data hub to basically collect and use this stuff. And it wouldn't be too hard. We could stand this up within a year or 2, and we could do it for less than $200 million. So that to me is a good investment that would really change things on the ground. We'd have a better understanding of what the problem is and how to deploy resources to correct it.
Well, the thing is that also the challenge, which also Esther mentioned, that every health system is sitting on a whole different electronic health record. And ONC has been trying to do health information exchange portals between those electronic health records, which are also kind of running off of their funding and steam, and they're still kind of sustaining on bare budget. And so it's really, really hard for one health system, one doctor's office to talk to the other. All of this data gets lost in the mix. The hub
And
part,
the tests are inaccurate also.
Can I just say though that if you did this, it would be the biggest burden reduction program on doctors and hospitals in the history of the world. We work with Temple University Health System. They've got 5 FTEs that do nothing but report. They fill out a form by hand, and then they scan that form, they put it on an email, and they send it to the Philadelphia Health Department and the Pennsylvania Health Department and the CDC. That is nonsense. We need to get away from that model and say, what is in your system that I can extract so that I have an accurate assessment of what's happening in COVID in your hospital today, whether it's utilization, ventilators, ICU bed census, remdesivir administrations, et cetera. That information is already in the system. This is the folly of what we're doing. We're reporting 2 and 3 times in the least efficient way possible.
I absolutely agree. And it's too much burden on the health system.
Can I jump in here for a moment, because I hadn't wanted to talk about this, but from 2009 to 2011, I was National Coordinator for Health Information Technology. We wrote the meaningful use regulations, and we put in place the meaningful use incentive system. I've tracked this area pretty closely. We did not invest, because the Congress did not provide direct funding for it. We did not invest in public health information infrastructure. And the public health information infrastructure at that time, and still at this time, is so primitive that the idea that you could blame the CDC for not collecting the data is really beside the point. The CDC can't collect the data because the states can't provide it. And they can't provide it because they can't collect it, and they can't collect it because there hasn't been internal to the states adequate information systems. So, and certainly they're not compatible with one another. It is now possible, I agree with Joel, that it is now possible to create a national health information system because we now have additional technologies that weren't available previously. However, it is not, you cannot presume that the manufacturers of PPE, our drug companies, all the private actors and all the systems will jump up and salute because someone says, would you please supply this data? There needs to be some element of either incentives or requirements that underlie and make reliable such a national information system. So now, the reason we don't have information exchange is complicated, but it's at least as much because we have hospitals competing with each other and not wanting to share information as it is because the government failed to provide the data. And that's why Senator Alexander, who's now retiring, was so supportive of penalties for information blocking in the 21st Century Cures Act, because he saw that the local incentives did not support the creation of national information systems in this country. They still don't. And if we wait for those incentives to exist spontaneously, we will be waiting for a very long time. And Congress, you're right, Joel, Congress can legislate all it wants, but if it just legislates and doesn't provide the funding or the incentives, it won't happen.
So David, you're talking about local incentives, and maybe this is something Amber can talk to.
I'm saying it costs money to get even just to get the EHR to spit out the data is not free. And why do it unless someone says you got to do it or pays you to do it? So just to wish it will happen. Plus it requires the creation of, so there's software, there's the application, there's the development of interfaces. It's a non-trivial activity. Plus a lot of data we need is not in EHRs. It's under authorities that are regulated by the FDA. So how do we know where there's PPE? We know because we have to find out where people manufacture it. How do we know where the ventilators are? It's in part because if we want to create them, manufacturers are creating them. So it requires a unified private sector activity that's not sufficient to look to EHRs, though they're important. We need to know where remdesivir is available, not just where it has been used in the past. So that's all aside. I think the private sector can do many things well, but it has to partner with the public sector, and the public sector has to do its part as well. And we can't wish the public sector out of this. I'm struck by the fact that if someone had said 5 years ago, you were going to encounter a crisis that's going to take more lives than the Vietnam War or the Korean War, and you need to plan for it, what would we do? What would we be willing to do in order to prevent that catastrophe from happening? And I don't think that's what we will face with the next pandemic. I think we need to understand that we would not have won World War II if the government had said, let's leave it to the private sector. We wouldn't have succeeded in the Korean War if the government had said, let's leave it to the private sector. And there has to be a balance between personal freedom and public action and collective responsibility in meeting truly mortal threats to our national welfare. This pandemic can take us down as a country. It can leave us way behind China as a world power if we don't get our act together and address it. China, with whatever through means that we don't consider acceptable, has nevertheless taken care of COVID. And their economy is on the rebound, and we are still suffering.
Well, I want to bring in Don here. I think we all agree that we should have a good public and private partnership for sure. I want to bring in Don.
Before we go there, Sally had a direct question for David, who can answer that around masking and why a national mandate and opening economy, how it's necessary. And I think
the best way for us to compete with China economically is to have everyone wear masks.
Yeah, I think they're linked together.
You're saying a national mandate then?
No, I didn't say that. I didn't say that.
I'm asking you, is that what you're saying?
I think we need to get to people wearing masks, and we need to understand that we have a responsibility to one another. The idea that you wear a mask to protect yourself is ridiculous. You wear a mask to protect other people. You wear a mask to prevent aerosolized spread of a very contagious virus. And that aerosolized spread is what is inhibiting our economy.
Yes.
I want to bring in Don here to talk about what your thoughts are looking at the data. And I don't know, I think we brought this up when you brought the data before. Did you look at, you know, the number of people wearing masks, the number of people not wearing masks? And by the way, I used to be the mask Nazi in my house. But then I heard that when you're outside, you don't really need to be wearing masks. It's also that younger kids don't really transmit to adults. So there's a lot of conflicting data out there, but I do agree that from an etiquette standpoint, a cultural standpoint, we should be wearing masks. I'm sure it is helpful. But Don, have you looked at that data regarding who's wearing masks and not? And then there's a couple of questions here for you.
I have not, because I don't think there is any data on who's wearing masks. There just isn't. You know, we can track your cell phone and find out if you're staying at home, and if you're not, we can tell the difference between whether you're going to a pharmacy or a grocery store. But whether or not you're wearing a mask would be a matter for a pollster to determine. And if a pollster calls you up one evening and says, I'm checking to see if you're wearing your mask because I'm taking a national poll, let's say you're not. You're going to admit that to a pollster? You're going to admit you're a bad actor who's not doing his job and wearing a mask? I don't think so. So, you know, there have been some attempts to do that kind of polling, but you know, it's not good data.
Yeah.
Well, this is as recent as 10/6/20, and there's correlation between states that support wearing a mask or recommend wearing a mask or mandate wearing a mask directly to the peaks that we are seeing. So there is, you know, there's no scientific doubt about it. There's a cultural doubt about it, and I do feel, you know, that a mandate.
Wait, there's actually a lot. Look, I'm not one of these mask deniers. I wear them, and I think it's a smart thing to do. Might help, can't hurt. But you just can't say with a straight face that there's a complete scientific consensus on it. You know, the great virus god Dr. Fauci was saying in February and March that you shouldn't wear masks, and now,
it has evolved.
And now you must wear masks.
Yes.
And the World Health Organization has waffled on this too.
Yes.
Let's all be honest. You know, we all want to sound like experts because it's good for our careers, and we all want to think there's some solution to this darn thing because that's a comforting fantasy to believe. But we don't really know if masks help or hurt. Now, because masks are a low-cost thing, if they don't help, well, you didn't waste a whole lot of time wearing your mask, and they might help. So, of all the things we could do, as opposed to like closing down whole cities, yeah, I'm all about wearing masks because it's so inexpensive. But let's not pretend. We don't know anything about whether it works. We don't know anything about anything when it comes to this virus.
Well, that's completely, as a clinician, that's completely incorrect. Few reasons.
Which part of it?
Yes, we have seen.
Well, that wasn't a yes or no question. Which part of it is incorrect?
That masks do not have any correlation with the incidence of any respiratory viral condition. It does. And yes, people have faltered in the past because the virus was novel and we did not know. But today, the science stands by the masks. And it is also data that it's as effective as any of the vaccines that have been prematurely approved in other countries. And it is also probably giving you a lower intensity of infection if you do end up getting it. So there is not only a protective mechanism to the community around you, there's a protective mechanism for the person who's wearing it. So there's a lot more data that is supporting clinically the use of masks, and it is directly impacting us to open up our economy. And so, and our livelihoods. So not only saving lives, but livelihoods. So hence, you know,
so I'd like to know, back in March and April, when we were causing a global depression by shutting down our economies to try to combat this virus, I'd like to know if you were saying with the same tone of assurance that you're talking now about masks, that that was a good idea.
Yes, I was.
Well,
And
then you were wrong.
Across
You were
the
wrong.
organization.
You were wrong.
Yes.
The evidence is you were wrong.
We did. We gave out free masks to all of our employees across the world.
You didn't understand my question, apparently.
I was wrong according to CDC or according to Fauci. Yes, maybe, but
that isn't what I said. I asked you if in March you were advocating the kinds of lockdowns that were done everywhere in the world, which I've shown statistically, and others have shown exactly the same thing.
Your data is not
work,
accurate.
and they had. Let me.
It is not accurate.
You
It
got
is
a lot
not
of
sound
screen
evidence
time.
at all.
Am I going to be able to get this out, or is everybody going to interrupt me?
Hey, Don, there is a question of causality from this question for you. What is the direction of causality for this correlation? And that's a question from the audience. Yeah. Do you want to answer that? That's
Well,
really
I mean, I think that, you know, we've shown an R squared of, you know, something like, you know, in the 0.3 to 0.4 range, which isn't really a very strong correlation. So I think the right question is, considering that there's really no correlation, is there any causality at all? And don't get me wrong here. I am not trying to make the point literally that we cause more deaths by locking down. That might be true. The data points weakly in that direction. But what the data tells you strongly, by telling you that there's no correlation, is that it sure didn't help. Now, something that's expensive and doesn't help isn't something you do. So if you're going to take expensive measures that impact everybody's lives, you better be able to look back on that and see some really strong correlation. And my work shows really very little correlation. Now, what little correlation there is, unfortunately, points the wrong direction. But the key message is how little correlation there is, especially in relation to the draconian undertakings that we put in place.
Well, I would say, and we'll probably have to wrap it up, that these shutdowns are also disproportionately affecting underserved communities, because those small businesses are shutting down. So I think there is something to be said about how do we help these underserved communities when a large number of them are small businesses. And so one of the ways we could actually do a better job with this pandemic, or with maybe we could help the livelihoods of those in the underserved communities. It is a balance. I get that.
Well, look, somebody, you know, if you can figure out how to help the people who got run over by this freight train, that would be really a big contribution. I hope you can do it. But I think we ought to try to learn from this, because someday we're going to have to experience this again. We've had pandemics in the past. There was one in 1957, there was one in 1968. And in none of those cases did we do what we did this time. And if it hurts people, and you know, if it helps make the moral case to point out that it hurts the people least able to protect themselves the most, then great. That just puts a sharper point on it. But we must learn that this novel approach to this novel virus to shut down the economy, to cause a depression, to try to suppress it, didn't work. And we have to take responsibility for that. We have to learn from that, instead of being all puffed up with pride and trying to protect our reputations because we all thought it was a good idea at the time. We were wrong.
Okay, Don, with that, I think, Archana, it's 1:40 and we have to, this is a 4.5 hour event. So I think some people have to take a bit of a break. I also want to just say that at 1:45, so let me just give you the calendar here. With 1:45 to 2:20, we have startups disrupting. We have 5 startups that are presenting, and a number of them have really good technology for remote care, as well as med pods, which is a fantastic idea that came from, thank you, Esther, one of her companies that she's invested in. So I want to save time for them. I also want to tell everyone, look, we are going to be talking about the pragmatic realities of this pandemic, which is, are we doing the right thing by keeping everything shut down? Should we be opening up? And so I know a number of you the panelists are already here on, but you are coming back at 2:20. That's going to be a really excellent conversation. So anybody who wants to stick around for that from the panelists here, we should. And then at 3:20 to 4:20, wrapping it up, we will do more on data. So this conversation will continue, but it is 1:42. So I'm thinking that we should shut it down we should take a break, unless you guys want to keep talking for a couple more minutes, and then I'm going to hand this over to Ethan.
Can I quickly end with this? Because Esther pointed out that this is not only just about pandemic, it is about several other things that it has led to. And some of the solutions that we will be discussing in our innovators section are addressing some of these footprints of our pandemic too. So thank you everyone for joining and having a spirited debate around our public-private partnership and the governmental response and how our politics impacts our healthcare. Thank you.
Thank you, Bambi and Archana.
Thank you. And at 1:45, Ethan will pick it up. And please, everybody stick around, take a break for a couple of minutes because you only have 2 minutes. Let's listen to these startups and let's get refreshed. Let's get out of politics. Let's get into creativity and innovation, hear what they have to say. And then again, we're going to come back and talk about reopening the economy or keeping it shut down. So I'm sure that'll be a lively conversation. So, okay, 2-minute break. And then Ethan, you're going to take it away.